Hello students, we have seen one of the methods of the direct assessment of nutritional status as anthropometric measurements, and today's class we will see about how clinical assessment is useful in the assessment of nutritional status. So, physical signs and symptoms of malnutrition can be valuable aids in detecting nutritional deficiencies. Essentially, clinical examination is based on the examination for changes believed to be related to inadequate nutrition that can be seen or felt in superficial epithelial tissues, especially in the skin, eyes, hair and buccal mucosa, or in the organs near the surface of the body such as parotid and thyroid gland. Occasionally, this may be supplemented in the field by certain physical tests with or without instrumental aids such as testing for ankle jerks. The WHO Committee on Medical Assessment of Nutritional Status way back in 1962 and 66 has conveniently classified physical signs often associated with malnutrition into the following three groups. The first group includes the signs that are considered to be of value in nutritional assessment. These are often associated with the nutritional deficiency. Signs of malnutrition may often be mixed and they may be due to the deficiency of two or more micronutrients. Group 2 includes the signs that need further investigations. They may be related to malnutrition, perhaps of a chronic type, but are often found in population of developing countries where other health and environmental problems such as poverty and illiteracy are collectively existent. Group 3 include physical signs that have no relation to malnutrition, although they may be similar to physical signs found in persons with malnutrition and must be carefully delineated from them. This usually takes a particular expertise of a physician or other health worker expertly trained in nutritional diagnosis. The WHO classification helps to identify particular nutritional deficiency when the survey is limited and aimed at rapid clinical screening of the community. In clinical assessment, the physical signs should be recorded as precisely and practically by a well trained personnel, and the interpretation must be based on standardized definition of a particular sign. Advantages of clinical assessment are: the clinical examination is relatively inexpensive method as neither elaborate field equipment or costly laboratory is required. With very carefully trained and continuing supervision, even a junior personnel can be taught to recognize certain crucial signs. It is the simplest and most practical method when two or more signs characteristic of a deficiency disease are present simultaneously. Clinical assessment gives valuable, if approximate, objective information to the public health workers. There are certain limitations of clinical assessment. What are they? A physical examination may reveal evidence of certain nutritional deficiencies which are not detected by dietary or laboratory methods. The clinical assessment sometimes gives false positive results due to non-specific signs of a particular deficiency disease. Then proper training of personnel is needed, and the procedure is non-invasive and the symptoms are observed externally, so that sometimes it may give a vague result. Now, coming to the clinical methods, a medical history and a physical examination are the clinical methods used to detect signs, that is, the observations that are made by a qualified examiner, and the symptoms which include the manifestations reported by the patient. These are associated with malnutrition and risk of chronic disease. The latter is defined by IOM as culmination of series of pathogenic processes which are response to internal and external stimuli over time that results in clinical diagnosis or ailment and the health outcomes. For example, this includes diabetes, cancer, coronary heart disease, stroke and arthritis. The signs and symptoms may be non-specific and develop only during the advanced stages of nutritional deficiency or even excess or chronic diseases. For this reason, their diagnosis should not rely exclusively on clinical methods. Now, it is obviously desirable to have the capacity to detect marginal nutrient deficiencies and the risk of chronic disease before a clinical syndrome develops. The clinical methods for assessing nutritional status: as a frontline health worker providing health services at the community level, he or she almost certainly encounter many people with nutritional deficiency problems. In addition to the anthropometric assessments, clinical signs can also be assessed and the symptoms that might indicate potential specific nutrient deficiency. Clinical methods of assessing nutritional status involve checking the signs of deficiency at specific places of the body and asking the patients whether they have any symptoms that might suggest a nutrient deficiency from the patient. Clinical signs of nutrient deficiency include pallor or pale tongue or on the palm of the hand or on the conjunctiva of the eye. Bite or spots on the eyes, pitting edema, goiter and severe visible wasting are some symptoms. Now, physical examination: there is a pattern of measurement for hospitalized patients. It depends upon the age of the patient, the illness and the degree of nutritional intervention. Nutritional assessments for patients with complex chronic diseases states should be conducted every 1 or 2 months or less often in those with milder diseases, every 6 to 12 months. The general physical examination includes an assessment of patient's general condition and close examination of skin, hair, teeth. The table that is given I will describe. This includes an assessment for pallor, clinical assessment of body fat stores, wasting of muscle mass, edema, skin rash, thinning of hair, evidence of specific nutritional deficiencies. Examples of specific signs include the flag sign or the loss of hair color associated with period of malnutrition followed by recovery with a return of normal hair color and the texture to normal. That means, when there is deficiency or there is the hair color changes and it becomes sparse. Then again, when the individual comes back to normal nutrition, the hair color becomes normal and the texture also becomes normal. So, it describes the number of episodes of nutritional deficiency an individual has. So, this indicates the flag sign. There is bands of light and dark color in hair. So, vitamin A deficiency causes follicular hyperkeratosis and night blindness. It is usual to see classic signs of marasmus and kwashiorkor in developed countries. Examination of specific organ systems and obtaining medical record information is helpful in assessing the severity of underlying disease process. It is important to consider the clinical judgment and assessment of nutritional status. Now, the areas that consider the nutritional examination finding inadequacy are: general is when there is underweight, short stature, edematous and decreased activity level. These indicate when there is underweight and short stature, it increase that indicates there is less calories over a period of time. And when there is edema and decreased activity level, indicates low protein level, and when there is overweight, it indicates increased calorie intake. Then the hair changes when there is easy pluckability of the hair comes out very easily the moment you hold it, and sparse hair, depigmented hair, lack of curls, dull, altered texture and flag sign, all these indicate that there is a protein deficiency. And skin, general, when there is cirrhosis, follicular hyperkeratosis, it indicates a vitamin A deficiency. Then if there is a symmetric dermatitis of skin exposed to sunlight and pressure and trauma, it indicates there is niacin deficiency and edema, deficiency of protein. Then when there is petechia and purpura, then when you find red spots, it indicates deficiency of ascorbic acid. And the scrotal and vulval dermatitis, deficiency of riboflavin. Generalized dermatitis, there is deficiency of zinc and essential fatty acid. Then erythematous rash around the mouth and perianal area, deficiency of zinc. And when you see the skin of the face, there is seborrheic dermatitis in the nasolabial folds, which indicates riboflavin deficiency. Moon face and diffuse pigmentation indicates the deficiency of protein. Then subcutaneous tissue, if there is decreased subcutaneous tissue, indicates the deficiency of calories, and if there is increased subcutaneous tissue, it indicates there is increased calories. So, nails, if you see the nails, they are spoon shaped or koilonychia, the deficiency is of iron, and when there is a long term deficiency of iron, the nails change into spoon shaped nails. Then eyes, when there is dry conjunctiva, keratomalacia and biter spots, it indicates that there is decreased vitamin A or vitamin A deficiency. Then circumcorneal infection indicates riboflavin deficiency. And the lips, angular stomatitis, the corners of the lips become white in color, they indicate the riboflavin and iron deficiency. Chelosis is the tongue becomes cracked and red in color, magenta color, indicates the B complex vitamin deficiency. Then gums, swollen and bleeding gums indicate there is vitamin C deficiency, and the reddened gingiva indicates, reddened gingiva is the reddened gums of the teeth, which indicate the vitamin A deficiency. And coming to teeth, the caries indicates fluoride deficiency, and stained teeth, there is decrease in iron supplements, and mottled pitted enamel again indicates deficiency of fluoride. So, this is, and when you come to the tongue, it indicates the glossitis, there is a shiny tongue, which indicates there is deficiency of niacin, folic acid, riboflavin and vitamin B12. Then skeleton enlargement, when you see there is costochondral beading at the ribs, it indicates the vitamin C deficiency. The craniotapes, frontal bossing and epiphyseal bossing indicates there is deficiency of vitamin D. When the bones become tender, it indicates deficiency of vitamin C. Muscles, when there is decreased muscle mass, there is decrease in protein and calories. The calves become tender, the thiamine deficiency is seen. Then when there is neurologic changes like ophthalmoplegia, there is deficiency of thiamine and vitamin E. When there is hyperreflexia, it indicates vitamin E deficiency. Ataxia and sensory loss, vitamin B12 and vitamin E deficiency. Looking at the endocrine and other glands, when there is hypothyroidism, it indicates iodine deficiency, and when there is glucose intolerance, there is deficiency of chromium. Then when there is altered taste, there is deficiency of zinc, and delayed wound healing indicates deficiency of vitamin C and zinc. Now, malnutrition among vulnerable groups. With all the clinical signs, we see how it occurs in the children and the pregnant ladies, adolescents and old age. So, malnutrition is defined as a pathological state resulting from relative or absolute deficiency or excess of one or more essential nutrients. This state being clinically manifested or detected only by biochemical, anthropometric or physiological tests. 4 forms of malnutrition are seen. One is undernutrition, the pathological state resulting from the consumption of inadequate quantity of food over an extended period of time. Marasmus and inanition or exhausted state due to prolonged undernutrition are synonymous with severe undernutrition, and starvation implies total elimination of food. Hence, the rapid development of severe undernutrition, marasmus or inanition. Then specific deficiency is the pathological state resulting from a relative or absolute lack of an individual nutrient. Then overnutrition is the pathological state resulting from consumption of excessive quantity of food and hence a calorie excess over an extended period of time. Imbalance is the pathological state resulting from disproportion among essential nutrients with or without absolute deficiency of any nutrient as determined by the requirements of a balanced diet. The main concern of malnutrition in vulnerable groups in developing countries is related to undernutrition and specific deficiency and imbalance. Vulnerable groups in developing countries, malnutrition makes its principal impact on young children, that is infants, preschool children and next to young children, and pregnant and lactating women who are nutritionally the most vulnerable groups. So, if we see the children of school age children between 5 to 15 years, they do not normally show any significant serious illness. Still less mortality from malnutrition. They are growing more slowly, they are able to compete for and digest the full range of adult diet, and usually they will be achieved at a substantial immunity against at least some of the infectious diseases. Adults, with exception of pregnant and lactating women, adults are the least vulnerable segment of the population so far as undernutrition is concerned. Nevertheless, certain groups need special consideration, for example, old people and persons engaged in heavy labor. Now, if we see the causes of malnutrition among young children, it is the economic and cultural factors and environmental factors. If we see the economic and cultural factors, first is the non-availability of food, then infections, non-consumption of protein-rich and protective foods, and ignorance. So, these factors lead are main cause of poverty. Because of poverty, there is non-availability, and when there is no food, infections are prone to occur, and because of low food intake, there is low intake of protein and protective foods. Then environmental are infestation and the ignorance again. Non-availability or consumption of protein rich and protective foods, there is inadequate food production in the area or unavailability. Then lack of knowledge, lack of facilities to process and preserve the protein rich foods or protective foods, lack of quick food distribution system from the area of plenty to scarce areas, then lack of financial resources to buy the protective foods. Poverty severely affects those who cannot grow their own food. Poverty affecting infants, health from the beginning if the mother's nutrition status is poor. Mother's employment or wage earning leads to early weaning without proper supplementation. Then ignorance and superstition, the failure to use pure food resources for feeding the infants and preschool children, lack of knowledge of nutrition needs for the children, then infants feeding practices without attention being paid to nutritive value and nutritional needs of infants, and traditional notions avoiding nutritionally rich foods. Then infestation, a majority of young children carry a heavy load of intestinal parasites, especially roundworms, which interfere with the nutrients. The poor malnourished child is heavily infested as it lives under unsanitary conditions where the water and food are likely to be contaminated. The hookworm infestation, found frequently in some regions, causes a constant loss of blood resulting in severe anemia. So, infections, the bacterial infections tend to occur frequently as majority infants live under unhygienic surroundings. Intestinal disorders due to the bacterial infection are quite common and often precipitate in the development of kwashiorkor and marasmus in the malnourished child. Frequent attacks of fever such as malaria or influenza may also induce the development of kwashiorkor and marasmus in malnourished child. So, malnutrition in early childhood, if we see the infants and preschool age children between 1 to 4 years, in infants the malnutrition or the nutritional status is affected by the maternal diet in pregnancy, the fetal stores of the infant, mother's own nutritional status, local methods of infant feeding, and whether the baby is having breastfed or artificial feed. When you see the breastfed infants, nutritional status of breastfed baby is usually excellent in the first 5 or 6 months. Growth is well sustained as sufficient protein, calories and vitamins are supplied by the breast milk. The only common exception to this is infantile beriberi, which usually occurs in the exclusively breastfed babies of the mothers whose diets are largely composed of thiamine deficient polished rice. So, intake of highly polished rice is devoid of the vitamin thiamine, and the peak incidence being between 2 to 5 months of age. This essentially maternal malnutrition transmitted to the suckling by mother's thiamine deficient breast milk. The infant may appear well nourished as judged by the weight, development of muscles and subcutaneous fat. Neither incidence nor prevalence can be ascertained by survey methods. So, it can be assessed approximately by age specific 2 to 5 month mortality rate. That means, even if the infant looks healthy, there is mortality between 2 and 5 months, and by hospital data concerning acute cases of infantile beriberi responding dramatically to the parenteral thiamine. In developing tropical regions, infant in the second half of the first year of life will continue to be breastfed, usually with inadequate supplements of largely carbohydrate gluons and pastes. So, more commonly the second semester of infancy is characterized only by inadequate weight gain and somewhat flattened growth curve, and sometimes by a degree of iron deficiency anemia. When you see the artificially fed infants, factors leading to the artificial food intake is urbanization, the mother's employment, influence of the advertisement of infant foods, the examples of socio-economic superiors, and for majority of the families in tropical regions, artificial bottle feeding is not a practical, economical and nutrition or hygienic. Economically, the imported animal meals and processed baby foods are too expensive. So, token doses are normally used. They do not use the normal dose. The milk is diluted and fed. Then nutritionally, mother is not educated to follow the necessary routine of preparation. So, dilution and protection from contamination is a doubt. Then hygienically, conditions at home, supplies of water and fuel, kitchen facilities, means of storage protected from insects, dust make the feeds contaminated. So, in these circumstances, majority of non-breastfed infants reared on bottle receive very dilute, highly infective feeds, resulting in most cases protein calorie malnutrition and sometimes associated with diarrhea and often leading to death. So, type of resulting malnutrition depends upon the artificial feeds of the child has received. You can see in the table how the food is diluted and what type of nutrient adequacies and other causes and resulting deficiency. So, if there is the diluted milk, there is inadequate protein and carbohydrate, and they give the carbohydrate gruels like arrowroot gruels, and this occurs between 5 to 7 months and results in infantile kwashiorkor. Similarly, there are vitamin deficiency and lack of vitamin A in such milks, so resulting in infantile scurvy and severe A vitaminosis and leading to malnutrition in the child. Then malnutrition among preschool children. So, when first to 5th year of the life also is a very important and critical period in a child's life. The 2nd year of life, the preschool age, especially 2nd year of life, is notoriously associated with the risk. It is a transitional period as regards to diet, immunity to infection and psychological dependence. Now, the factors associated with nutritional status of 2nd year old preschool children is, it is a period of rapid growth with high nutrient needs, then increased protein needs for swiftly growing muscle tissue. It is the time when the several meals of the day are required. Food should be easily masticable and digestible. Non-immune child accumulates bacterial, viral and parasitic infections. Psychological trauma of separation from mother due to the 2nd child and discontinuation of breastfeeding frequently caused due to next pregnancy. Then malnutrition occurring in preschool children. The principal forms of malnutrition seen during the transition period are protein calorie malnutrition or protein energy malnutrition of early childhood, common in developing countries and nutritional public health problem in the world. Then second one is the A vitaminosis A, rickets, then iron deficiency anemia. The incidence of these, it may vary from different places, and the protein calorie malnutrition of early childhood, it is a generic term to cover mild to severe classifiable and unclassifiable manifestations, including the two main severe clinical syndromes of kwashiorkor and nutritional marasmus. Now, kwashiorkor is the main incidence in the 2nd year of life. It can occur in infancy and preschool age and even in adults, very rare. Kwashiorkor is a nutritional imbalance of the diet that is low in protein, but contains more calories. So, the etiology of kwashiorkor, it is never exclusively dietary in etiology because of infections, the psychological, cultural and other conditioning factors, either in a single or in combination. But the principal cause is always nutritional imbalance in early childhood. If you see the clinical picture of kwashiorkor, there is degree of deficiency and the ratio of carbohydrate calories to protein intake and the velocity of onset, the age at which the patient is affected, the duration and the conditioning factors like infections, psychological trauma. Psychological trauma is when the child is withdrawn from the breastfeed because of the 2nd pregnancy, the child does not like it and it psychologically get depressed. Then genetic characteristics, example the skin color and the type of hair. Now, constant signs of kwashiorkor, first there is edema, which is detected by the production of definite pitting in the pre-tibial and lower end of tibia when moderate pressure is applied with the thumb. Then growth retardation, there is a low body weight which is 68% of the standard weight in treated kwashiorkor, and a low mid arm circumference which is 77%, and body length is less affected because it is a short term malnutrition. Then muscle wasting and retention of some subcutaneous fat. There is a reduction in the upper arm circumference, presence of subcutaneous fat reflecting calorie intake in the form of carbohydrate calories. The psychomotor change is this child is apathetic. Apathetic is it does not have any interest in the surroundings. It is miserable, inert, withdrawn and anorexic. So, does not have any appetite to eat. So, his motor development is also retarded. And the usual signs of kwashiorkor are there are hair changes, there is dyspigmentation, loss of curls or it becomes straight, then silkiness, then loosely attached roots, you can just easily pick up the hair, and sparseness, easily pluckable. Then there is diffuse pigmentation of skin, the skin becomes light in color, and there is moon face. The pathogenesis of moon face is uncertain. When you see the moon face child, you feel the child is chubby due to a fat with a degree of edema, but it is because of the edema face becomes moon shaped. Then there is endocrine dysfunction, there is hyperadrenalism and anemia which is not severe unless associated with hookworm infection or malaria. Now, the occasional causes of the kwashiorkor are flaky paint rash which occurs in advanced cases, hepatomegaly, extreme fatty infiltration leads to enlarged liver and often associated with splenomegaly or malaria. Other skin lesions include sores, fissures behind the ears, moist groin, rash. Then associated vitamin deficiency, they have keratomalacia and angular stomatitis. Then associated infections, again you have the other vitamin deficiencies. Then nutritional marasmus. Marasmus refers to the second severe syndrome of protein calorie malnutrition. The term is imprecise, but clinically descriptive. Refers to a young child showing severe wasting principally due to grossly inadequate diet. The etiology is severe undernutrition diet, very low both in protein and energy, so called balanced starvation. So, most common in the first year of life, in contrast to kwashiorkor which occurs between 1 to 3 years, and it can also occur at all ages including adulthood. So, attempted artificial feeding with dilute milk and often associated with infective diarrhea and sometimes associated with tuberculosis. Then late form of childhood nutritional marasmus due to prolonged breastfeeding not supplemented with any other foods is called as breast starvation. Clinical signs of nutritional marasmus, there is growth retardation, extreme retardation, then weight retardation and more than length weighing 60% of the standard weight. And occasional signs are hair changes, minor abnormalities, there is light brown, somewhat sparse, unlike in kwashiorkor where the hair becomes very light and pluckable. Then there is wasting of muscle and subcutaneous fat, the arm feels very thin and skin becomes loose like an old man. The measurements of arm circumference and skin folds of upper arm and muscle circumference are very low. Then associated with vitamin deficiencies like keratomalacia and angular stomatitis. He is called a little man or a monkey face. Then associated conditioning diseases, dehydration due to infection of diarrhea and oral monoliasis and chest signs of tuberculosis. Then there is intermediate severe syndromes of protein calorie malnutrition. Then frequent cases of which are intermediate between the two clinical mountains, that is kwashiorkor and nutritional marasmus, which cannot be defined in precise terms. The interrelationship between two major syndromes resulting in transition form of one clinical picture to another. So, early kwashiorkor child, there is infective diarrhea, ill advised and prolonged therapeutic starvation, which leads to nutritional marasmus. An infant with nutritional marasmus is because of inadequate breastfeeding, which again leads to kwashiorkor in the second year of life, when only carbohydrate foods are given. The next deficiency is the A vitaminosis A or deficiency of vitamin A. This is again the most dangerous manifestation. Keratomalacia principally affects the young preschool children and is often associated with moderate or severe protein calorie malnutrition. It is a disease of poverty and ignorance with diet restricting vitamin A like milk or fish, and the sources of carotene, green leafy vegetables and papaya. So, at times it is due to an early cessation of breastfeeding. Artificial feeding with vitamin A deficient dried skim milk, poor body storage of vitamin A particularly in twins or premature infants, then infections like diarrhea and measles act as the conditioning factors. Now, assessment in the community will be direct assessment because of clinical signs, low levels of serum vitamin A and diet survey. And indirect method will be hospital admissions with keratomalacia, local standards for age, incidence of blindness which is called as weanling blindness in toddlers. Ecological assessment, cultural evidence suggesting A vitaminosis A, Bitot spots as scaly like a fish and night blindness as chicken's eyes. Then infantile beriberi is one more deficiency symptom in infants. The infantile beriberi is the only form of malnutrition occurring in young breastfed infants, attributed to maternal dietary inadequacy, that is low thiamine in her milk. The direct assessment for this is long term incidence surveys, examination of pregnant women for clinical signs and urinary thiamine, estimation of breast milk for thiamine. And indirect assessment, age specific mortality between 2 to 5 months, then statistics based on infant treatments responding to thiamine. Ecological assessment will be the knowledge of local pattern of feeding of infants and mothers. Then rickets, young children who are not given vitamin D as food or as supplement, where they are not exposed to sunlight. Direct assessment will be the lack of specificity of many signs of rickets, its prevalence in young children, high serum alkaline phosphatase levels, then the radiological examination of risks of suspecting cases. Indirect assessment will be outpatient attendance and admission of children with rickets. Ecological assessment will be the dietary pattern of children and mothers, women, cultural practices of excluding child and mother from irradiation and UV rays of sunshine. Then iron deficiency is a nutritional deficiency caused because of bacterial or parasitic infections, genetic abnormalities like sickle cell anemia, suboptimal liver stores because of malabsorption. So, direct assessment will be the hemoglobin screening, low levels investigated by cell morphology or microhematocrit, then common associated causes like stools for hookworm, blood for malarial parasites, etc. Then indirect assessment will be the number of children with iron deficiency anemia in the hospital area. Ecological assessment, dietary studies and availability and absorption of iron present in the diet. Now, nutritional assessment of school children will be the clinical assessment for Bitot spots, conjunctival xerosis, anemia, parotid enlargement, angular chelosis, fluorosis, dental caries, goiter, tropical ulcers, hepatomegaly and splenomegaly. Now, if we see the malnutrition in pregnancy and lactation, next to young children, pregnant and lactating women are nutritionally the most vulnerable group. So, causes of malnutrition in pregnant and nursing mothers: in some areas, women may be a constant state of nutritional stress from the time of early marriage before growth has ceased until the premature death in the age of 30s. That means, when the adolescent girl is got married and she becomes pregnant, both the mother and child are in a growing period, which is a vulnerable period. Then whole of adult life may be continuously reproductive, as pregnancies and prolonged lactation follow one after the other without pause. Nutritional needs are high, as many women are responsible for heavy work carried out without the efficiency, and clumsy tools continued throughout pregnancy. Malnutrition aggravated by food customs, especially applying to women in pregnancy and puerperium. Fleshy foods are prohibited in East African pregnant and lactating women. All the above factors lead to cumulative nutrition drain, often termed as maternal depression syndrome. So, this maternal depletion syndrome is less degree of PCM in women and childbearing age, failure to make expected weight gain during pregnancy, decrease in subcutaneous and fat muscle tissues, and low birth weight of neonates, then premature aging of women and early death. Specific maternal depletion syndrome is osteomalacia, iron deficiency and iron deficiency goiter. And if your nutritional assessment of pregnant and lactating women include the clinical signs, where you see for angular chelosis, pretibial edema, conjunctival pallor, goiter, bone pains of osteomalacia and suggestive signs of beriberi. Nutritional anthropometry, weighing at regular intervals throughout pregnancy, and biochemical tests, testing for serum vitamin A levels and hemoglobin levels, combined anemia, nutritional anemia and megaloblastic anemia for folic acid and vitamin B12 deficiency. Indirect assessment for maternal mortality. Perinatal mortality is the mortality in the first 7 days of after delivery. Then the OP records admission cases of anemia and pregnancy, osteomalacia, beriberi, and birth weight of the children. Then factors associated with birth weight of neonates. Neonates are the first 28 days after birth, where the meta shows the maternal nutrition, genetic influences, maternal ill health and overwork, smoking habits in the pregnant woman, placental malarial infection, pregnancy of multiple births, lack of prenatal supervision and obstetrical abnormalities. So many signs we have seen to assess through the clinical assessment, especially in the vulnerable groups of the population, who are the infants especially and the preschool children and pregnant and lactating mothers. So, we have found that clinical assessment also is a very important form of assessment of nutritional status. Thank you.